All right. So, thinking about the pelvis and relative motion versus total motion, and when, you see maybe compensatory strategies up or down the chain.
Mm-hmm.
I was thinking about squatting, as I tend to do a lot. And I was just thinking, so if it, I understand in a squat, you want to get counter nutation at the sacrum. You want external rotation of the anomalous, at least to start. And I know as you descend, you go through the arc, but is there a way to, can you visually tell with your clients when you're getting that actual counter nutation, or is it you shouldn't really see anything because it's relative motion at the pelvis? Does that make sense?
Yeah. I mean, during the descent, I don't think you're going to be looking at necessarily if it's counter nutating or not, but what you're going to look for is the full range of motion. So at the top, the first 60 degrees of descent, if you're looking to do a squat that is biasing counter nutation, then what you would look for is basically a stacking of visualize the respiratory diaphragm being stacked over the pelvic diaphragm.
Mm-hmm.
You're looking for that as much as possible. You're looking for a little bit of a posterior tilt, and we could talk more about the difference in a posterior tilt is sort of a broad general term, and it matters if we're referring to the sacrum or if we're referring to the ilium, if it's during inhalation, if it's during a concentric kind of active muscle contraction. But at the beginning, you're just kind of looking for that stacked position. So rib cage over pelvis, which usually will lead to more counter nutation for most people, right? So it's important to say, what kind of squat are you trying to do? If you're trying to do a squat where you're teaching someone to get their hips back, get their knees back, a hinge to
a low bar
squat with a hinge, there's nothing wrong with that. And in many cases, that's necessary when you're under the load, especially of a back squat, because you're not going to get good expansion posteriorly with the back squat, and you're not really meant to. So you may need a different strategy to squat with load that way. And I think it's important to understand that. So that's going to start with some nutation of the sacrum, right? As you go down there, and you, depending on your depth, you may keep relative nutation most of the squat, right? So when you're looking at your assessment for counter nutation, I think the best way to do it is can somebody go ass to grass, or can somebody make that lower, that contact with hamstrings to calves at the bottom of the squat, and just sit there and rest there. And if they can, then they probably have pretty good counter nutation. Now, most people that we know aren't there, but that's the difference. You know the people that can get there, but yet they can't touch their toes, or they have some other issues.
Right.
That would be, and that's sort of the difference between the archetype of the wide versus the narrow. A lot of times the certain wide might be able to touch their toes because they can nutate the sacrum, but they certainly can't sit in the bottom of that squat. So sitting in the bottom of that squat would be one version of saying, okay, they have counter nutation. At the top, it would be looking for what would look like a posterior tilt, but it's also going to be, the intention is to really stack the respiratory diaphragm over the pelvic diaphragm. Does that make sense?
Yeah, because if you don't start in that stacked position, there's little chance you can get the full depth position at the bottom. Is that?
Yeah. I think that's the case, but it's also good to look at what's the intention of why would we want to why would someone need counter nutation, and why might someone not, right? And it's not it's not like we want as much movement as possible into counter nutation. We just want enough to get that relative posture of the respiratory diaphragm over the pelvic diaphragm. And if somebody's already counternutated there, we certainly don't want to counternutate them more, right? So we just have to look like for that balance, because whether somebody is starting counternutated or somebody's starting nutated, like that's the goal, is to kind of get them in that middle position to start, right? So, because that allows for the best breathing dynamics, right? That allows for any time that you inhale, the middle of your diaphragm kind of pushes down right into the middle of the pelvic floor. Then you get this sort of trampoline effect of inhale pushes the pelvic floor down, on the exhale it's coming back up. If the sacrum is moving, you know, into too much nutation, then it's kinked, right? Like that airflow, that pressure flow is kind of kinked, and vice versa if it's too much counternutated. So that's ultimately the intention there that you're going for. And then as you descend into the squat, you're seeing if you can basically keep that the whole time. And, you know, a lot of people can't. So, but that's the assessment of, I'd say, like what I like to refer to as like a mobile squat, right? Do you have the optimal mobility, or does there have to be some type of compensation? Well, as soon as you throw load into the mix with different, you know, loading parameters, right? So, or, you know, loading strategies, back squat being one that's very common, you're going to have to compensate in many ways, right? Just because you're closing certain areas down up the chain. And in order for you to keep, it's going to be very difficult basically to just drop straight down without some type of nutation, you know, or hinging pattern first.
So then, I mean, does it ever become, do you just train those movements separately, like, or treat them as different movements to a certain extent? If you want to back squat, if someone wants to back squat and you back squat them, then do you just separately train that more counternutated respiratory squatting pattern to just give them access to that range, even though you understand that when they're back squatting, it's going to be different?
Yeah, I think it makes sense to do that. I think it makes sense to look at the ideal, I guess, mobile squat, you know, being able to get full counternutation at the bottom as its own kind of mobility drill, but it also is a counterbalance to what you're not getting from your heavy loading. And you can really look at that. You talked about relative motion versus absolute motion, or, you know, there's different ways to describe that, but basically, like if you're trying to get mobility of a specific joint, you're not going to get it when you load it too heavy, right? It's just, that's not the intention. I mean, some load can be helpful, but it has a different intention then. Like you can use load to sort of hold an area in place while you're trying to actually get relative motion from another joint. You can use load to maybe add a little bit more force in the direction you're trying to go from a mobility standpoint, but it's certainly not going to be the most load possible. And that's what oftentimes strength training is trying to get you to build how much load you can handle. And in those cases, you're not thinking about relative motion. You're thinking about really like movement associations. You're trying to take all of the muscles that would irradiate well together and have them move well together, right? As opposed to trying to separate out one joint from another, which is what relative motion is. Oftentimes, if we're trying to get more joint mobility, the two opposing joints, or the two closest joints, are sort of doing the opposite thing. Versus when we're looking at kind of keeping that association, that irradiation, it's like everything's working together, everything's co-contracting, right? So they're opposite things. So yeah, it makes sense to train them as different things, right? Even though you can categorize something as a squat, it's just important to understand, you know, what your intention is and what your goal is. And specifically with the squat, depending on what you're training, it could be almost opposite ends of the spectrum. Right? But both are important. Like, so somebody who can get all the way down into the squat, oftentimes, and like we work with, I'm sure you've worked with people like this, I know I have, they suck in that middle range, right? So they'll be able to like sit all the way down into the squat, but if you want to put load on them and have them just kind of go halfway, they struggle. They'll really overhinge, it's not like they can kind of keep that whole way down, because that mid-range of the squat oftentimes is your body needs a little bit more nutation there. Your hips need a little bit more internal rotation, and that's what they don't have. So you might be training them with a hinge squat, with a nutated squat, but like minimizing maybe how much trunk, forward trunk motion that they get. You might need to cue them onto how to find internal rotation there, and just be stronger, basically get more concentric with the pelvic diaphragm. So that halfway point is oftentimes where like a power lifter will go in their squat, maybe a little bit lower than that. Mm-hmm. But that is where you want more of a nutated sacrum, right? So for the people that can drop ass to grass, it's often they aren't as good in the middle, and that's what you train them, but that is training kind of more that nutated position.
Yeah. And those are like those people who are struggle in that middle range are like the ones who they can drop down, but it's like they almost have to try to bounce out of the hole to get back up to a certain point.
Yeah, or they
try to concentrically
it depends on if they have load or not. If they don't have load, what they'll do is they'll just bow forward, and it becomes a version of a roll-up to stand, or they just hinge their way back up, but it's usually a really aggressive hinge.
Mm-hmm.
And it's not like a maybe optimal hinge. It's a kind of in between, like the shoulders go forward and then it's a roll up, because the sacrum doesn't counter-nutate that well.
Mm-hmm.
So a good assessment is like just do a forward bend first and then drop into the bottom of a squat. And that usually bypasses the challenge point for somebody who can't nutate, right? Just to see, and then for the person that nutates well but can't counter-nutate, they might be able to touch their toes, but then you ask them to sit ass to grass, and then something will happen where they can't do it. So that's an easy assessment of just do a forward bend, toe touch, knee straight. When you kind of run out of room there, then you drop into the squat, and you usually can see the difference there pretty easily. Like the counter-nutators won't be able to touch their toes all the time, but they'll be able to sit in the squat. And then the nutators might be able to touch their toes, but they can't sit in the squat. And it's, you know that there's in-betweens there. There's going to be a lot of people that can't touch their toes and can't sit in the squat. And then there's going to be some that can sit in the squat and then can touch their toes. But it is interesting when you look at the people that you would look at as like they're really hypermobile. That's what you would think of, because they can sit in the bottom of that squat. But when you actually keep their knees straight and ask them to touch their toes, they can't do it. Because I mean, they might get close, but they're not there, and you would expect them to be like palms to ground. And if you think about it, like from a standpoint of like the sacrum there, right? So here is like your nutation, right? And here's your counter-nutation. If somebody is held in counter-nutation and you ask them to bend forward, it's like they're in a deficit to actually touch the ground. So they need to kind of go up, and now you can see how that's a better forward bend. Yeah. So if they're like held in this position, it actually is like a little bit of a deficit to be able to touch your toes. And it's interesting because if you add a little bit of a knee bend, they usually can get it. But if you really make them keep the knee straight there, you can see the difference.
That's interesting. I guess that makes sense as to why that's such a useful assessment.
Yeah. And if you think about the sacrum, right, is this central element, right, of the pelvis, where a lot of times the ilium, the ischial tuberosity, they're thought of when we think about like pelvic tilts. It's like pull the sit bones down, like have the hamstrings pull the sit bones down. And that's valuable, but that's a different type of pelvic tilt than thinking about nutation and counter-nutation of sacrum, because with normal respiratory mechanics, right, you're going to get, again, opposite relationships there to what the sacrum is doing and what the ilium is doing, right? So when you inhale, you'll have that counter-nutation, you'll have that the accepting of the guts. So the counter-nutation is basically like trying to make a floor, a bony floor, for the guts coming down. right? And then you'll have the opening of the paddles, if you will, of the pelvis. So, right, you got like these guys open up to accept the guts, but under here, this tucks under to kind of catch the guts. But that's just bony, right? And that doesn't take into account like what's happening with the muscles of the pelvic floor. So this actually brings everything closer together down there to catch the guts, but opens it up a little bit more here.
Okay.
Now, when we think about an actual pelvic tilt, a lot of times we're thinking about it from like a concentric, actively created strategy, as opposed to an eccentric, which would be like just the inhale is creating motion there. So when the inhale creates motion, it's going to create a posterior pelvic tilt by moving the sacrum into counternutation, right? Because it's going to it'll move and you can look at the counternutation is also, look at the base of the sacrum. It's moving back while the apex, the bottom of it, is moving forward and under. So that is actually a back bend of the sacrum. So you can think of that as extension of the sacrum, but you'll get flexion, so relative motion again. Then the next segment up, the lumbar spine, is going to go into relative flexion. There's always those kind of opposites when we're looking at relative motion. But that extension there of the sacrum becomes the summation of that, right, becomes things are moving back. The base of the sacrum is moving back, and then the spine is moving back. So you get this posterior motion, right? So we call that a posterior tilt of the pelvis. That's one way to say it. But that's through an inhale. Now, if we have somebody, say, get into a 90-90 position and get their proximal hamstrings engaged, well, now we're not on the sacrum anymore. We're on the ischial tubes here. We're on the pelvis, or the ilium part of the pelvis, and ischium. So now as we engage that, we still move, and this is traditionally what people think of as like, where do the ASISs go?
Yeah.
So that's still a posterior pelvic tilt, I think, in depending on the terminology you're using, because it's still moving things back, but it's concentric. It's through active motion. So at the sacrum, the concentric action would be the posterior pelvic floor, right? Because it's going to pull the tailbone forward as you engage up, right? The coccygeus and those muscles there that are actually attaching to the coccyx, they're going to pull you into active counternutation along with pulling the iliums in that posterior motion. So both can happen at the same time. When you're thinking concentrically, you're thinking on an exhale in that case. So it's almost taking you a little bit away from what your normal exhalation mechanics would be, because you're overriding that with muscle contraction. And that's, I think that's a point, that certainly has been a point of confusion for me, because in different movement practices, yoga, and Pilates, you'll get these different cues for like a butt wink, holding a fart type of thing for the posterior pelvic floor. And oftentimes it's done during the just global flexion of the sacrum, the lumbar spine, and everything's just kind of moving in that direction. But that has to do with active contraction. So that's going to be a concentric element that'll tend to be during an exhale and things like that. It's still moving into a posterior tilt. You just have a different, different orientation, basically. Like you're doing it actively.
So then, like, do you use them both at the same time, or is it more like, do you go to that concentric action using the proximal hamstrings to posteriorly pelvic tilt? Is that more, are you using that when someone's entire pelvis is anteriorly oriented, to just bring it back under them first, and then that following inhale when they're in that position gets them real counternutation or full counternutation or something?
Yeah, you can superimpose one on the other. It depends on what you're going for. So say somebody is caught in counternutation, right? The narrows, and they do have like a full anterior orientation. So I can have the coccyx held here, but then I can just bring everything forward like that. but I
Yeah.
haven't tipped this back yet, right? This is still in that place. So in that case, where are my ischial tubes? They're sticking back. I still need to pull them forward.
Yeah.
I just might not be so heavy with my cueing for the posterior pelvic floor there.
Yeah.
I might just be trying to find, I'm probably going to put people, and just think of it this way too, I'm probably going to put people in that 90-90 position there, somewhere that promotes a little bit more internal rotation, right? And it's a concentric contraction. So we're looking to do that a lot of times with people that are overly counternutated anyway. The focus will be on bringing those ischial tuberosities forward and getting them to be a bit stronger into maybe internal rotation, extension-based movements. So I'd want to probably be in that arc of about 90 degrees flexion, working on at least to start. But I think the key is to be careful with what you're cueing, right? Or what you're trying to get. You're not trying to get a ton or very, like you're trying to get zero lumbar flexion, right? Like we don't want to go there pretty much. We want to look at always finding that stacked line of the respiratory diaphragm and the pelvic diaphragm. So if you're on your back in 90-90 position, still get it's a horizontal line. At that point, you're trying to look for that, and just giving people cues. Now, I've definitely had people that are in that narrow, kind of archetype, that you put them into too much flexion at all. Like even if your intention is to try to get the proximal hamstring, just being in that kind of flexed hip position, it makes symptoms worse because there's an instability there. It could be that there's a difficulty actually controlling, not overly flexing, not overly like creating more flexion of the lumbar spine, more counternutation.
Yeah.
So you have to figure out different positions sometimes that the body starts in a little bit more quote unquote neutral throughout, right? Not promoting the hips to be there. But it might also be that there's just more of a need to say sequence differently. Like you might ask for more inner thighs. You might bring a block into the mix and like totally neglect any idea of having them pelvic tilt in that way, like just putting them in a position where when they exhale, they feel like their hips are going into the socket. They're getting some engagement of the proximal hamstrings, but no idea of trying to tilt the lumbar spine off and go into that flexion. That makes sense. So like for both like narrows and wides, like you're always trying to find that mid-range position a lot of times, right? It's just that there's a different starting point, an almost opposite starting point.
And then, so for wides, if they're already like, if you think about the archetype of a wide who, if there's no other compensatory strategies, they're in that more IR, internal rotation zone of things with the nutated sacrum, IR, ilium. So would you even put them in a 90-90, or would you just do like a hook line or something where you're in that less hip flexion? And then would that more take them closer towards counternutation because it's not in that internal rotation zone of things?
Yes, I think two things that are valuable with a wider angle. And first, you got to make sure that they can decrease the threshold of anything they're doing. They got to turn the volume down on any contraction you're asking them to do. That often takes some time, right? Just some focus on longer exhales, however they can get them, might be a good starting point. But once you have a little bit of control there, the exhale will focus on bringing the rib cage down and in. Could be pursed lips. It could be getting those like the external obliques to pull the ribs down into more IR, right? Then the inhale, without losing what you gained on the exhale, you could think about breathing into the base of that sacrum. And oftentimes a hook line position, if you're lying in hook line, you can feel the base of your sacrum a little bit better on the ground. So if you can feel the inhale expand the base of that sacrum into the ground, that's usually enough to get started without so much of a need for pulling back hard through the heels or anything like that.
Yeah.
Because then you risk getting too concentric there and you know, going a place you don't really want to go.
Yeah.
All right. So, but you can try to get more flexion with these people in the lumbar spine. However, I think it's important to make sure that the breathing is there first, and the proprioception of also just being able to move pressure into the base of that sacrum. I think that's really important. However, if you can't get that good exhale that brings things down first at the ribs and gets maybe you can think of it as like external obliques bringing things down, but just ribs down idea on the exhale. Or if you lose that on your next inhale, then you're not going to feel that into the base of the sacrum, right? Because you're just going to go and extend again to inhale.
Yeah.
So having that relationship of exhale, ribs down, and then the next inhale, don't lose what you gained with that ribs down, but just bring that inhale into the base of the sacrum. So you're trying to go more anterior, posterior with your inhale, right?
Yeah.
But more specifically like posterior, where you're trying to do a back bend with that sacrum. That makes sense? So playing with the angles where people can feel that the best makes a lot of sense. The other thing you can try is, you know, obviously the bottom of a deep squat with assistance. That's a gradual process depending on how wide someone is. But I think it's very valuable for me, and I definitely am towards wide. When I feel compression and I know to inhale and expand into that compression, it's super valuable for feedback, right? So if I can get myself into a position where I feel my thighs on my belly, well, that's creating a compression that I can breathe into anteriorly there. But then usually there's a sense that I can create that more of an anterior posterior if I can get enough inhale there. So just getting to that space where you feel you're sinking, however you need to do it, holding onto a pole, holding onto a TRX, elevating your heels, but just being able to literally sit in the bottom without too much strain, and then take a expansive inhale. And you'll know when people are ready for that or not, but you can assess it just by having different ways to assist them into that bottom there. And if it's too hard and they're just too high threshold when they're down there, they're not going to get as much out of it. But I look at it as it's a worthy process. So I might start people there early just for my own personal assessment to see, okay, yeah, they're struggling there, but I want them to get used to getting down there, right? Because the practice of doing that becomes something that they can see progress with. So now, like the first day you get someone that's real wide in feeling that compression, they just might feel like they're suffocating. They might be able to spend like 10 seconds there before they come up. But just, it's like anything else, progressive overload, don't overwhelm, but just introduce that discomfort and teach them that, all right, what you want to feel is to be able to breathe there better, right? Because that's a whole assessment process in itself.
Right.
But there has to be some cueing for where you're breathing. If it's too hard, though, you can't concentrate on moving pressure, right?
Yeah.
So then you can take that idea, though, of the belly to thighs, and then you could put like a wedge right under someone's sacrum and put them into a position where they're either pulling their knees to their chest, or you can put their feet on a wall in a position where the belly and the thighs come as close together. Now there's not nearly as much pressure there. They have more feedback to breathe right into the wedge with the back of the sacrum. Plus they have gravity helping them now a little bit because things are moving posterior with gravity, and that's what you want, at least on the inhale. So that would be how I would look at working that. But I think, and I've certainly changed my way of viewing this with the wide, especially the people that are wide but also very high threshold, and they have a hard time turning down the tension, is not to make it so much about muscle contraction, but make it about that inhale, and can you feel yourself breathe into the area that is compressed, that is restricted. And that may just be like 2 minutes. I give them initial cueing, and then I shut up and let them just focus. And then like, does that get better with more practice? And then eventually, like in a session, that becomes like a cool down. That becomes at the end of every workout. Like, is that better? And it really does get better. You know, like people will just report where it's like, I didn't know what the hell you were talking about. Now I could feel it. And once that happens, that's a lot of things open up, that you now have some buy-in, but like you can start to do other positions that would be more challenging for them to feel that. And now they have a better understanding of what they're going for, which really just leads to more of an idea of like dynamic posture. So if they can feel that inhale where they want to feel it now, we could put them in standing. Can you feel it there? Half kneeling. Can you feel it there? Right. And so once they get that idea, and you can also tell when it's harder to feel, and that usually indicates that there's a position that isn't optimal. There's a compensation.
Yeah. All right. And then it's like sometimes for those, I'm just thinking, because we were just talking about why, it's like sometimes if they can't get into those positions, is that when you'll go with a like reciprocal activity if they can't necessarily feel that expansion bilaterally, because then you can create more compression on one side and maybe force pressures to expand on the other side in a certain way?
Well, I think I won't necessarily, if they can't feel, I need to find the position where they can start to feel that breath better, right?
Mm-hmm.
So I'll manipulate that a bit. Now, it doesn't mean that that's all that's being done either. Like, I just think you want to separate this out. Unless somebody's just in a really bad place with pain and they can't exercise without increasing their pain. Like generally, like there's still going to be a exercise and conditioning phase for this person, right? So in those cases, that's where I think the rotational stuff comes into play, understanding that they're not perfect with the mechanics of breathing and things like that. But when they're moving a little bit faster and the intention is different, biasing a person that's, let's say, nutated more than counter-nutated, right?
Yeah.
Biasing them to more rotation and biasing them to some positions that are a little easier for them to manage. So like sideline positions, being careful with stuff that's like plank oriented, that's quadruped oriented. But I would do that in more of not a specific corrective standpoint all the time. It would be more of like actually incorporating that into a fitness routine. Mm-hmm. So because you know that they're not going to be so great at the stuff when you ask them to do it bilaterally, because they've been having trouble when you're slowing it down. But when we are slowing it down, I actually wanted to get that centrally first before starting to shift things too much. And I've made that mistake. I make that mistake all the time, just because sometimes they just get a little impatient, or there's just like more stuff I want to introduce because it can get boring to have people work on the same thing. So I'll introduce stuff that I know that they're maybe not ready for, just to even make it that, all right, this is what you want to be able to feel this. If you can't now, you go back to that first one, and just so they can maybe see the bigger picture. But a lot of times they need to put more work on that central. I don't even think of it as bilateral. A lot of times I just think, if you're really thinking about the sacrum and you're thinking about like the pelvic floor, the respiratory diaphragm, like that idea of finding the stacked line, it's central cueing. So we want to bring things back to the center before we shift it.
Mm-hmm. Yeah. My next question sort of is, I guess, thinking about, like, I feel like people talk about stretching hip flexors and all that all the time, but I'm just curious, what's actually happening under the hood when people are complaining of that anterior hip tightness, whether it's like, I'm thinking of like hip extension and like, you know, you put them in a half kneeling and their down leg, the front side is just like on fire. Is there something happening underneath the surface of the pelvis? Like I don't know. I'm just curious.
So wait, what position are you talking about?
So like people talk about stretching their hip flexors,
Right.
like putting them in half kneeling. And I'm just thinking, like, what's actually happening at the pelvis when they're when they're presenting with that anterior hip tightness? What are some underlying mechanisms, and like, how do you go? Is there another way to go about it? Or what are some ways to go about reducing that for people? Because I feel like that's really common for a lot of people.
Yeah, so it comes back to, let's bring things to the center as much as possible. So whether you have somebody who's biased into counternutation or biased into nutation, there's usually a value to having somebody eventually get into half kneeling, because there's a lot of assessment that can come there. And if you're feeling more distal symptoms, right, like the whole quad, say, is on fire of that down knee, that usually would indicate that we need to do something to get the mechanics up and more centrally working better, right? So that could be for either. A lot of times with the more counternutated narrow presentation, right, like you're going to get more of a sensation of just not being able to hold your position, but a lot of times hurts on the knee because there's not enough upward concentric control, right? So the breathing dynamics have to be, very important there. But if you don't have that stacked respiratory line over the pelvic line, then you have a problem again. And it's just, again, the starting position is a little bit different. So for somebody that is more kind of compressed in the back, the wide presentation, right, you're looking at being able to get that same breath that you were trying to get in supine, but you're trying to get it now where gravity has a different relationship. The muscles often have to work a lot harder just to not fall over, right? So it's a much more complex position to be able to get your body into that place. And oftentimes, as soon as you put someone there, they just feel like their quads are on fire.
Yeah.
That's the thing that's holding them up at that point, because they're not balanced, up the chain. Right. But if you can so if you think about it from just a perspective of taking stuff out of the front and bringing it to the back, right? So if you feel the front of the thigh is on fire, and my next inhale can go into the top of the sacrum and it moves it back, well, now I'm starting to counter that. I'm starting to balance things out a little bit. And if my next exhale then can pull my ribs down, pull my belly inward, pull the pelvic floor upward, maybe biasing more towards the posterior pelvic floor, now I'm starting to take stuff away from the front of the thigh, and I'm starting to bring it up towards the center again, right? So it ends up being the same mechanics. It's just more difficult, right?
Yeah.
So you have to, I look at half kneeling a lot of times as how you would look at the bottom of a squat for some people, right? It doesn't seem to be as demanding on mobility, but it absolutely is, right? Because we're looking at like end range hip extension there, where when we go into the bottom of a squat, we're looking at full hip flexion on both sides, but we're also looking at the rotational components and really the end range components of that counternutation of the sacrum. So when we look at end range of hip flexion or full hip extension, we're really looking at we want to be able to counter or to nutate well to get extension there. Right. So a lot of people are going to miss that full extension of the hip. So they'll feel like they can be there without any support, but they're definitely just not getting that last little bit. So giving support, maybe putting hands reaching into a wall can be a good start for people, just so that they can have a little bit more control for how they breathe. And it just appreciating that it might be too hard, but that doesn't mean that you don't put people there, just to kind of get an initial feeling. And as you're doing other stuff with them, you bring them back to that position. Like, I'm not a believer in that if you put somebody in a position that they're not ready for, that they're going to fall apart. It's detrimental to them. I think it's important as an assessment point. It's just, you don't want to let that be your only intervention if it's too hard for someone and think that they're actually going to make much change. But I like to put people in positions that eventually you want them to be rock stars in, because I think it is so valuable. It's like starting at the finish, basically, which is, I think, is a Charlie Weingraf, phrase, but it's basically you start sometimes where you want them to be, knowing it's going to be a little bit too hard, so they can have that feeling of what they feel now. And you want to ask them that. You want to, like, where do you feel this? You want to give them maybe some cues in the right direction, appreciating that it might not be perfect for them. And then you know where to regress to get them more of what you want and what they need in that position. But I think it's not like a step-by-step process where you're like, okay, I can't go into this position until they have some type of pseudo-perfect in this other position.
Yeah.
It's just it's a back and forth. And then things start to open up in all positions. And then you realize, like, how a position actually does affect your breathing, which I think is very valuable for people to understand, where the easier positions become very open. They become very, like, you can really move pressure very easily. And then the positions that were more challenging, you feel like you can actually now get a little bit of that pressure that the therapist had been talking about, but you couldn't feel it all. Well, now you can feel it, but you feel how much harder it is than when you were in the easier position. So you realize, like, how gravity plays a role, how just tightness in certain muscles, because you're in different positions, play a role. But there is no doubt, like, muscle tension in the hip flexors. It's just, it's not like the feeling of the stretch is not going to make that better.
Right.
I think that's the thing to separate out. The more you feel things proximally and towards the center, a lot of times you're getting yourself into a better position, right? But if you can't breathe there, right? If you're forcing yourself only concentrically, right, by pulling yourself hard into maybe some hamstring cueing, some inner thigh activity, and then you can't take an inhale there without totally, like, falling back into the position, like, you don't have it, right?
Mm-hmm.
But there's always a kind of a continuum there. So for some people, it's good to go concentric and just teach them how to feel the difference between no cueing to their own body, just like being in that position and struggling in that position, to what happens when you start to, say, draw your hip into the socket there, and you feel a little bit of adductor, you feel some hamstring on that side. What changes on the front side? Does that move the stretch from distally towards the knee, towards the groin? Okay, now you have a little bit of relationship we can work on. What happens if you pull back through the front heel while you're sucking up? So both sides are sort of compressing. You know, your left side, your front side's going into the socket, the back side's going in the socket. Do you feel things more centrally? Do you feel things up and more proximally? And then you can just have them sort of relax on the inhale and then just focus on the exhale. And then you might do the opposite. We're just focused on the inhale here. Just think about inhaling. Can you feel the back of that sacrum? And visualization really helps, and it really matters with this stuff. And there's some research on how, you know, plenty of athletes, you know, get some benefit just from visualizing before they go and do their sport. Well, it shouldn't be that different for when you're actually working on these real subtle things with anatomy and breath, because it becomes less subtle, just like sports become less subtle for people that are good at it, right? Stuff that feels like impossible for someone that doesn't play a sport, it's just automatic for someone that's a master, right? So these movement things have a similar process of learning, that you just have to give people the time to practice in a way that's not going to hurt them.
Right. Yeah. I was thinking about, like, people, I feel like sometimes people, like, you'll see clients that seem to have, if you just analyze, like, their static standing, just like, look at them standing, and sometimes if they present with sometimes, like, one hip will appear higher than the other, like a hip hike or whatever you want to call it. What's happening there, and how do you go about going after that?
It's hard to say what's happening there, right? So and I don't always view it that way. Like, I care at first.
Mm-hmm.
I just want to bring things back to, how do I get people back to the middle again? How do I get people back to moving from the center out? And then usually in that process, you can see there are obvious asymmetries that need to be deconstructed and worked on. So if you start looking at hip rotation a lot with a shift there, you might see some obvious asymmetries there that would have to be worked on. But again, in order to address hip rotation, you have to be able to address the pelvis centrally first, so that you're basically putting the sockets in the best and most optimal position to have rotation. Does that make sense? So it's sometimes when things like look really complex and really asymmetrical there, it gets overwhelming until you bring it back to like the same mechanics. It's like, all right, where are people at with breathing? When I take gravity and I take weight bearing out of the mix and I just put them on a table, like how do they look then, right? What can they do? What can they not do there? And then you kind of branch out. So I think it's always good to start centrally, and then you can look at the specific asymmetries later on. Okay? And a lot of people will clean up to a point of not perfection, because that doesn't exist, but just if there's a symptom, a lot of times symptoms will come down, and you've given somebody who feels that they're broken somehow because they're so asymmetrical a way to make themselves feel better. And sometimes it's a matter of how you, depending on what the client's looking for in those cases, right? If it's just something you see and they don't have some type of psychological connection to having a longer leg or being asymmetrical, then you don't bring it up, right? Like just work on, just work on basically, understand their motion throughout their body, but you're usually not going to address the asymmetries right away anyway. You just kind of bring things back. If somebody does have some type of connection to this asymmetry and they want it fixed in a way, you want to, the word you use will be, well, what we're going to try to do is bring you back to your center, back to your core, whatever language you think would help them. And that helps you control the asymmetries that we all have in our body. And then it'll also likely make it that we're starting from a better starting point to get you more symmetrical. All right. But I think focusing on like really trying to be very exact with that asymmetry isn't always valuable at first. And if somebody's already got like some psychological baggage with that asymmetry, which I've been seeing a lot more over the last several years of working, just because people look stuff up. There's so much now of talking about these presentations of asymmetry, and like people have a little bit of the information, but they don't have enough experience to really understand it. So that little bit of information becomes anxiety and becomes a sense of I'm broken, as opposed to understanding, that it's pretty natural to have these asymmetries side to side. And a lot of professionals will make a career on saying, like, I fix, long leg or leg length discrepancies. I fix, these problems, and that's causing all of your problems, right? So people are marketing that, and it just leads to some things that could be not helpful, definitely for progress. So, and for me, it just, maybe I'm not good enough with that stuff, but I find it always easier. Let me just come back to fundamentals a lot of time, which is just bringing things back to the center, and a lot of things can be helped. The other way to look at that, though, that is if somebody's having a specific symptom that is unilateral, and you are connecting that symptom to something that makes sense with that asymmetry that you're seeing, you use the symptom as a way to maybe guide something that's more one-sided than the other. So for instance, someone's going down into a bodyweight squat, and they have a shift that you're seeing, but they're also getting a symptom, let's just say like the outside of the knee on one side. You may give them some cueing to shift their body weight to one side or the other, understanding the kind of hip shift mechanics and things like that. But instead of going right for a hip shift because you see somebody who is what appears to be visually very asymmetrical, that you still need to make sure that they understand that central mechanics first, or that hip shift's going to be shit. It's not going to be what you want them to be.
Yeah.
Right? But it can be very valuable, like, to just give somebody like a reference of asymmetry to counter a symptom sometimes, right? So let's say like someone's got lateral left knee pain when they go into a squat, and you give them a cue to maybe pull up into the left adductor when they go into just the left, right? When they go down, and that makes their symptom better. Well, that's helpful, right? Yeah. That doesn't necessarily mean that they need to have all of their exercises be unilateral, focusing on that left adductor. It just means that you just gave them a little bit of a reference to really quickly change a symptom, which helps. And then you can do that in many other ways too. But I would say like the brunt of the program would still at least start central until you kind of run out of any progress there.
And even with that, it's like you think about just cueing someone to, I mean, in whatever cues you use to shift them to a side in a squat, it's like, you're not having to teach them a completely new exercise, and it's like you're just slightly biasing things to a side in a bilateral activity, so that, like, I guess there's just more specificity in that case, if that's what brings if that exercise tends to normally bring their symptom on, and then on top of that, there's less coaching or learning involved, and it's easier for them to feel that transition or change of symptoms.
Absolutely.
Which is, I guess, just kills two birds with one stone to a certain extent.
Right. Yeah, and I think that talks to like the feeling of a muscle contraction, right? Trying to cue someone to feel a muscle contract. To me, it's not about building strength so much as it is just about like proprioception and having like a reference for a subtle change of position that is necessary. But the same thing happens with an inhalation, which isn't so much muscle contraction oriented, but it's more, feeling pressure move oriented. So when you're making a muscle contract, you are, you're compressing, right? So you are changing pressure in your body, but that it has a different kind of voluntary action, to it, right? So it feels like it's more something that you're doing and you have control of, where inhalation doesn't always feel like that for people, where like that you can breathe and move your breath and expand in different places, but both are just as valuable. And all they are, though, is references for, position at a certain moment in time, right? So if you get somebody to feel their adductor well on a regular basis, and that's valuable for them and it takes a symptom away, it's not that useful unless they can do it on a regular basis. It's not going to just be helpful by doing 10 reps of it. It needs to be something that becomes an education as part of their body. And then position can change, which then makes it easier to have that muscle reference. Right. And the same thing with an inhalation reference. Like if it's easier to move pressure when you inhale and you feel it in these positions on a more regular basis, it doesn't, like, you don't have to stop being aware of that you have to continue that awareness throughout. It's just that it gets easier to feel that awareness when you call on it. Right. So it doesn't have to be some special program that you're doing. It just becomes whatever position I'm in, I can tell if it's easier or harder for me to activate these cues, and that will give me some reference to what my position is, but that can also give me an indication if I'm close to a stress that might be painful. And so it's all of this is an education for people, right? These muscle references, they're not like, okay, if I strengthen my adductors, I'll never have pain in my knee again. It's never that. And I think that's really important to understand. If you do a certain amount of weeks of physical therapy, you'll never have pain again. That's not true unless what you've learned carries with you. And so learning is the key. And sometimes you can get learning that's kinesthetic and it's almost automatic, right? Where you don't have to consciously think about it that much. But it's not going to be like, if you go back to all of your same behaviors and you've not learned anything, and you just passively hope that the exercise is going to take hold, that's just a pipe dream. That's fiction.
Yeah.
Right. And pain then is more complex than that too. But with what we're trying to do as therapists is really be educators through movement. All right. So movement is a part of it's a learning style that often gets neglected when we think about like learning in a classroom, for instance. You listen, which is auditory, you see, visual learning, but we often don't move. Like when you have a practical or a lab-based class, that would be kinesthetic learning. But for a lot of things, even in physical therapy, which is all about understanding movement, we didn't move that much. Like we didn't go to a gym, we didn't actually do exercises. We thought about how we would program them theoretically, but we didn't actually feel them oftentimes. And that's what we're trying to get people to understand is like, you got to feel the things that hopefully the therapist can feel in themselves.
Right.
Like it doesn't mean you can do everything perfectly. It just means you know where you're restricted. You know what you feel that you're asking someone else to feel, right? And because that's really important. Because otherwise, like you're just missing that whole element of kinesthetic learning that you're trying to get out of somebody.
Yeah, absolutely. And I mean, I feel like that also just makes it easier to connect with clients because you understand where they're coming from.
Right. And
there's always a good chance that whatever they're feeling, like you could have the same restriction.
Absolutely.
And then when you work through it or figure out ways to work through it, then you have a better avenue to possibly educate them or direct them to do the same.
Absolutely. And you realize how hard what you're asking someone to do might be.
Yeah.
And as you get better as a mover, you have to remember how hard it was for you to get better too.
Yeah.
And I mean, I think a lot of things in health and fitness are that way. Like nutrition's a good example too. Like if you have your nutrition down and you've been really thinking about it for years, you might forget how hard it was before you did that. Right.
Yeah.
And then this is what you're asking your clients to do. So it's important to remember your journey when you're helping someone else, because they might just be getting started. But as you go through your process, you can realize you can get more empathy, but you also realize like how dynamic the process is, how it's not static, right? That you could have been doing this stuff for years, and just you wake up in the morning and it's not there for you. Later in the day, it's there for you, right? Like different points of the day, you can feel things that you're asking your patients to feel. So you get that you have to be patient with your clients because you have to be patient with yourself.
Right. It makes sense. No, it's helpful. It's helpful to just think about going into school. Hopefully, I mean, we'll see how that starts. But do you want me to go with another question, or do you want to?
Let's save it for next week. I got a couple things that I gotta take care of today. But no, this was a good one. And if you have any follow-ups from this, because I mean, we can do more imagery with it, but I know you have pretty good background for being able to visualize the anatomy, which is pretty impressive since you haven't started PT school yet. But it's like what we're talking about here can be pretty complex, right?
Yeah.
So, and it's still stuff that I'm absolutely working through. Like for instance, like you helped me with my book, and like when I was talking about pelvic tilts in the book, whenever I was talking about like the mobile squat and things like that, definitely had a different understanding than I do now. It's not, I don't think what I wrote, like I wouldn't rewrite it necessarily, because I have a more simplified version in there, and I don't think what I wrote is incorrect. I just think it's incomplete, but it has to be incomplete sometimes to simplify. So this to me is a way more in-depth conversation about pelvic tilting that can go deeper. But I look at that, like a term like sciatica is very general. It doesn't really mean anything. It just means that something hurts in the distribution of the sciatic nerve. But people will try to make that a specific thing. And I think that's what pelvic tilting is in a way. It's like posterior pelvic tilting. And I think it's good that we have this conversation so that there is a difference with context, and there usually is. So that's where you get into the world of fitness, where people are at each other's throats because somebody used a term differently than the way they're using it. But I think if you understand it from all context, then you can, no one's really wrong. You just understand where they're coming from at that point in their learning process. So that's this conversation here, certainly.
Yeah, absolutely. Yeah.